right. So I think glad you guys can hear me. I'm doing well. Happy Wednesday. Happy virtual rounds day. My name is Olivia Snyder. I'm a fourth year med student at the University of Iowa, Carver College of Medicine, and I'm applying into anesthesiology this coming match cycle. So please pray for me. So originally, I believe Stephanie was scheduled to give a talk about brain tumors today, but she had a conflict. So we swapped dates, and I'm going to be talking about a radiology topic. We're going to go over some chest x-ray basics, and then she's going to do the brain tumor talk, I think in the first or second week of August. So you should definitely stay tuned for that when that comes up, because she did the spinal cord disorders, and I know a lot of people wanted to hear more neuro. So yeah, that will be next time, or not next time, but in the future, but me for today. So as always, we're going to go through our simulated patient case, the physical exam, and the differential diagnosis. We'll come up with an assessment and plan together, and then we're going to spend the bulk having a lesson on kind of the pathology, but because this is more of a radiology talk, I'm going to discuss kind of the different imaging modalities and kind of the approach that we use to systematically read a chest x-ray, as well as highlighting some common conditions that you might see on a chest x-ray that you should hopefully be able to identify by the end of this. So please participate, please ask questions. I love when people are interactive and asking questions and even answering each other's questions in the chat. So that always makes it really fun. And then if you are able to open the link for the SOAP note, I did put that in the chat. If you have any difficulties with accessing it, then please let me know. I had also gotten a message saying that it looks like last week somebody was having trouble with submitting the SOAP note and quiz. So if that happens to anyone by the end of the session, then please let me know so that we can make sure that you are all getting your certificate, okay? So this is the SOAP note and the quiz. Hopefully you can access that link, and if not, then let me know and I can repost it. And then while we are working on that, I will turn on the annotation so we can mark our location here. I'm in Eastern Iowa, in Central Time Zone. It is very hot and humid here today. I hope that some of you guys are not having as much of the humidity as we are. Hopefully Southern California, it's a little bit nicer. Okay, I'm gonna clear our drawings. Oh, Texas, oh my gosh, you must be even worse off than Iowa. All right, I'm clearing the drawings and we're gonna turn off the annotations. Thank you guys for participating. I always like to see where you're tuning in from. And we'll just jump into our case. So today we have a 28-year-old male who presents to the emergency department after a motor vehicle collision, and his chief complaint is shortness of breath. So this is all good information to put in the subjective portion of the note. This is just kind of us getting a history from the patient and what happened. So the onset of when this symptom of shortness of breath started for him was very sudden, just minutes after the accident. He also is experiencing this unilateral left-sided chest pain that previously was not bothering him. And he was a restrained driver and had a seatbelt on in the car, and has no other symptoms besides a small laceration, a little cut on his shoulder. So given that he's having shortness of breath and unilateral chest pain, what would be some conditions that we think could maybe be causing the symptoms? And are there any major, like, do not miss, possibly life-threatening diagnoses that we'd want to consider? You can either unmute yourself or you can put something in the chat, whatever you're comfortable with.
He's probably maybe having abdominal bleed from the force of the crash.
Absolutely.
Or like it's even restraining him.
Maybe yeah, so with this being a restrained driver with a seatbelt, you get a lot of like concentrated force on that abdominal and that chest area. So especially with it being like on the left side, we would want to consider like a spleen, possibly like a splenic laceration. Sammy said a broken rib, which is exactly the right way to think, especially with having that chest pain. A pneumothorax is a great idea as well, because with having shortness of breath, and just to clarify, if anyone doesn't know what a pneumothorax is in like normal people language, it means a collapsed lung. And we'll go through the pathology of that a little bit later. But one of the telltale signs of a pneumothorax is after a trauma, you have shortness of breath and like one-sided symptoms. So certainly that would be another reasonable thing to consider. So you guys pretty much hit all the ones that I had, and here's just a couple of bonus ones. Pulmonary contusion is basically a bruise of the lung. And so that can cause certainly chest pain. And then usually the shortness of breath might be a little bit more delayed if you're like filling up those air spaces with blood that's kind of starting to dry and like become hard. So that's definitely a very serious diagnosis. Some people end up in the ICU and on a ventilator for that. Pneumothorax, we talked about, that's a collapsed lung. A hemothorax, if you're looking at the root of the word, pneumo meaning air and thorax is like your chest. A hemothorax is hemo means blood and thorax is the chest. So this is blood in your pleural space. And both of these, either the air or the blood, is compressing that lung and causing it to collapse. Other things, cardiac contusion, again, like in the pulmonary contusion, contusion means bruise. So like a bruise of the heart, you get this like anterior trauma that can kind of make the muscle not work as effectively and have like a temporary injury to that. A very serious one would be an aortic dissection. That's your main blood supply to your entire body. And so if you have a dissection of that aorta, then you're seriously going to have some major problems and you need to have surgery like ASAP to fix that. And then somebody who had said an abdominal bleed, that's also a very reasonable diagnosis. I'd thrown in splenic laceration, but you could also consider a liver laceration or any other sort of just like soft tissue trauma to the abdomen. So this is not an exhaustive list. This is just a few things that might be consistent with the history and a couple of do not miss diagnoses as well. So what else in his history would you guys like to know? We kind of have the short term, like the HPI of his present illness, but are there any other things that we would like to know to kind of get a better understanding of his health?
Okay, I'd like to know if he lost consciousness on the ride to the hospital.
Absolutely. Any like neurologic symptoms, that sort of thing?
And concussions, and I guess I'd like to know if there's any fractures or his temperature changes, his blood pressure dropped recently.
Yeah, absolutely. In the chat, we're also seeing if he has like a smoking history, if he has any other past medical history that we would want to be aware of, previous heart diseases, if he's on medications, if he has like previous like pre-existing cardiopulmonary issues that would cause him to be possibly more compromised. I don't know if you can hear, my husband is like cheering at some sports game that's going on right now.
Oh yeah, I kind of can't. I guess
just ignore him.
I got it. So, my next thing would be maybe substances, because maybe you don't see the drinking or not.
Yeah, that's true. Also, like if he's in a car accident, like was he under the influence of like alcohol or drugs? If that's also a good thing to know. So I would certainly ask about all of those things. But just for sake of trying to stay like not too complex with this, I just limited this slide to his past medical history, family history, social history. But I, again, would ask all of those questions. So his past medical history, he has Crohn's disease, which is an inflammatory bowel disease of the GI tract. And he was diagnosed with that at age 22, so about 6 years ago. And the only medicine that he is on is an immunosuppressive medication for this. So this, in this acute presentation of trauma, probably, isn't contributing to this pathology he's presenting with, but we would also maybe be concerned with his immunosuppression that he might have possible problems in the future with either like poor wound healing or susceptibility to infection, things like that. But in the short term, this doesn't really change our thinking or our management. His family history is non-contributory. Again, like in this acute trauma situation, we're thinking like very physical causes, very like mechanical and not so much like an intrinsic pathology. So family history is not super relevant for this particular case. And then social history, he is in graduate school for a PhD in engineering, and he is married to a husband with no children. So good work, everybody, with our history taking and the subjective section of the note. If we need to go back at all, then please just let me know towards the end, and we can get you any additional information that you might need for this for the SOAP note. But moving on to the objective portion of the note. So we're going to start off with our physical exam. First, we're going to take a look at his vitals, and if anybody knows like kind of normal ranges for vitals, then please feel free to chime in with anything that looks abnormal. But I'll just go ahead and read them. So his blood pressure is 108/76, heart rate's 98, respiratory rate is 26, temperature is 37 Celsius, and his oxygen saturation is 89%. So let's see what you guys said. So oxygen's kind of low, blood pressure is a little low, respiratory rate's high, and yep, fast breathing. So you guys totally nailed it. Normally for blood pressure, we like to have it be around like 120/80. So this is like kind of on the low end of normal for that. Definitely like with his history, we'd want to consider like possible bleeding or blood loss that could drop his pressure significantly, but this is holding pretty steady. Heart rate is kind of borderline, like anything over 100 is going to be tachycardic, and that can also mean like distress, but he's still slightly under that, so that's good. Respiratory rate and oxygen, though, however, are going to need some work. So normal respiratory rate is less than 20, well, like usually like 12 to 20. So with him being 26 and with his oxygen saturation only being at 89%, we're definitely looking at some sort of respiratory compromise that's happening right now. And then his temperature is normal. So looking especially closely at his respiratory exam will be important. Moving on to the rest of the exam. So he is just in mild distress. He appears as stated age. For his head and neck, the head, ears, eyes, nose, and throat exam, his trachea is slightly deviated to the right. So typically when we look at someone's neck, and if you can like palpate your larynx and like kind of follow it down to your like above the clavicle, everything there is going to be midline. And when it's shifted over to one side, then that makes us concerned that there's some sort of airway pathology that's going on. For his cardiac exam, he has a normal rate and rhythm, no murmurs. His pulses are equal bilaterally. So that gives us a good sign that he doesn't have any like peripheral vascular trauma or any sort of like bleeding elsewhere on his body. For his pulmonary exam, so the official word for a fast respiratory rate is tachypnic. Tachy you might recognize from like tachycardia, where you have a fast heart rate. And then that's just like the I guess, what is it? The suffix for breathing. So tachypnic means he has a high respiratory rate. He also has absent breath sounds on the left side, which is very concerning because you should hopefully have equal breath sounds. And he's also hyper-resonant to percussion. So percussion is a physical exam technique where you take either your fingers or like a reflex hammer or something, and you kind of like tap on the back or on other parts of the body, like the abdomen, to try to be able to hear what's underneath where you're tapping. And so if it's hyper resonant, it sounds almost like you're hitting a drum, like there's a lot of air underneath. You can have really like tympanic sounds if you have like a lot of gas in your abdomen, or if you have like a collapsed lung, for example, can cause that in the chest. On the other hand, if you have like low resonance to percussion, then that would maybe indicate that you have more fluid buildup or some sort of solid like consolidation of the lung. That's like the opposite of having too much air. You don't have enough air, and then it kind of sounds dull to percussion. So I know it's kind of hard to imagine without having like a good example, and I should have found a video. I always like to put videos in here. But unfortunately I didn't have a good video for this. So that's kind of the significance of his exam. The rest of it's pretty unremarkable. His abdominal exam, he's not tender, he doesn't have any distension. So that helps us feel confident that he doesn't have like any abdominal or organ dysfunction or trauma. And then his extremities, just a few scattered abrasions and lacerations, but nothing like severe cuts or severe bleeding or things like that. I guess before we move on, does anybody have any questions about the exam or about his history right now? I'm going to text my husband really quick to stop yelling. You can take a quick break. Okay, we'll move on. So this is his chest
My
X-ray.
first question is, since he has Crohn's disease, sorry? Okay.
Yeah, go for it.
I was wondering, like, since he has Crohn's disease, how does that like impact his risk of intestinal bleeding?
Yeah, that's a great question. So, it certainly would. So, Crohn's disease is an inflammatory, it's an autoimmune disease. So, you have like higher concentration of abnormal, like white blood cells and other inflammation going on in the gut. And so, the presentation usually is like pretty severe diarrhea and bloody diarrhea. So, you do have kind of a compromised mucosa of the GI tract because of that inflammation. And so you can actually have just like chronic bleeding in the intestines and in the colon and things like that. I'm not sure if it makes you any more susceptible than a person who doesn't have Crohn's disease or inflammatory bowel disease, if in a trauma context. I think certainly, like we said, if he did have some sort of abdominal like penetration or perforation, then he would be at higher risk for poor wound healing and for infection because of his immunosuppression and also just because of that chronic inflammation. But I think that if we're looking just at mechanical causes of that trauma, that I don't think he would have any intrinsic disposition to bleeding or other problems with that. Again, just speculation. I'm not sure if that's actually evidence-based or not, but I haven't seen it personally. So does that answer your question?
Yes, it does. Thank you so much.
Absolutely. Thank you for asking. Okay, so because the rest of this talk is going to be about how to read a chest x-ray, I just want to kind of see like off the bat, are there any things about this, or is there any approach that you guys would like to take to try to identify what might be wrong here? Or just like general observations. It doesn't even have to be like, I think it's this diagnosis. Like you could just make a comment about what you see.
I think there might be fluid because I see a bunch of like white marks on the left side of the lung.
Mm-hmm.
Fluidy.
Mm-hmm.
I noticed the heart gets swollen, inflamed. And yeah, his diaphragm and spleen are really inflamed because I see a little like scarring at the bottom, but maybe that's normal for Crohn's people.
Mm-hmm. Mm-hmm. Great observations. Yeah, a great way that you can start off is just kind of comparing the two sides when you have something that's symmetrical like this. And obviously we have the heart that's kind of in the middle and it's not fully symmetrical, but especially when comparing the lung fields, it's a great observation to, I think you're referring to this, that might be fluid. And yeah, that's like a big blood vessel. That's your pulmonary artery right here branching off. And you don't see that on this side because this whole lung is just shriveled up into like a little raisin. And so all the stuff that's supposed to be inside of the lung, like the blood vessels, are not visible on this side. This is just empty space here. And same with the diaphragm, like it's this, if we're calling this the normal side because we have normal vascular markings here, and this would be like a normally expanded lung. This one, you can tell it kind of drops off more steeply, and it has that like sharper angle down here. So those are like just in comparing symmetry that are standing out to me. Some other things that you had commented on about like the scarring down here. I think like, so we'll talk about how x-ray is not super great for soft tissue evaluation. What we would expect to be down here is the stomach. And sometimes you can even see like a pretty clear air bubble, and that can be normal or a variation of normal. But so much of radiology you'll find is like just positional, and like if the patient's in a weird like position, or if they had like something, if they had just recently eaten, that things are like more in a distorted view. So it's not a perfect system by any means. But yeah, it's great that you're picking up on details like that and wondering like, is that something that's normal? Is it like just artifact or a variation of normal, or is it something to be concerned about? So Great observations. The other thing I wanted to point out was like looking at his midline structures here. So this is like the vertebrae in the back. And with this resolution, like it'd be really hard to pick up on signs of that. But this also here, so this kind of more lucent area is the trachea and the airway. And you'll notice that it's kind of pushed off to the side here. So that is, again, like just correlating with the exam findings of his trachea being slightly deviated to the right, that you're also sometimes able to visualize that on an x-ray. So just wanted to point that out. Okay, so we'll go through in a lot more detail, like the steps for reading the chest x-ray, but I thought that your guys' initial thoughts were really good. We'll go into the assessment and plan just to finish up our note, and then we'll kind of dive into the rest of the topic. So for our assessment and plan, we have this 28-year-old male with a history of Crohn's disease, and he presented after a motor vehicle collision with shortness of breath and left-sided chest pain. So his exam was significant for tachypnea. He had tracheal deviation, and we saw that again on the chest x-ray. He had absent breath sounds and hyperresonance to percussion on the left side. So, and then his chest x-ray findings were consistent with a left tension pneumothorax. So the plan for this patient is going to be to start him on high flow oxygen, because if you remember, his oxygen saturation was pretty low at 89%. And we certainly don't want it to get any lower. We're going to, obviously try to treat it and treat the cause, but symptomatically to help him feel more comfortable and to help to get his oxygen levels back up, we can just start him on oxygen to supplement right now. And then to actually treat the pneumothorax, we are going to do a stat needle thoracostomy to get rid of that extra air that's compressing the lung. It's going to help let it out, kind of like if you're popping a balloon. It'll like let all the air rush out of the pleural space and allow the lung to like properly inflate. And then you follow the thoracostomy with a chest tube, and then you do another chest x-ray to confirm that you have it in the correct place. So for this plan, we'll revisit it at the end of the presentation, and I have a video to show you guys kind of like what those procedures look like. But just to have it started in your note here, I wanted to have it included here. Okay. Before we move on, does anybody have any questions about our assessment and plan for this patient? Great work with working through it though. Very nice. Okay, and also if we're going too fast or too slow, just let me know and we can always, go back if we need to or slow down. All right, so for the pathology lesson, like I said, it's going to be kind of more of just like a general radiology lesson, as well as showing you guys some pathology of common findings on chest x-ray. So why do we do x-rays, specifically chest x-rays, versus doing other studies? So the other studies that are available in radiology are commonly like CT, or it's computed tomography. You can have MRI, which is magnetic resonance imaging. You can have PET scans, which are like fancy MRIs, and you can do ultrasound. So there's a lot of different ways to image someone, and it depends what you're looking for on what to use to decide what you're going to do. So the reasons we use chest x-ray is because it's super inexpensive, like one of the least expensive, probably second to ultrasound. It's tests that we can order compared to CT, and especially MRI is very expensive. Chest x-ray is also very accessible and it's very fast. So almost any clinic or hospital that you go to, like they basically have to have an x-ray machine in order to like function properly. But not everywhere actually has other machines like a CT or an MRI, especially in rural hospitals, low income areas, medically underserved cities or towns that do not have a lot of resources. They might not even have the other options available. Additionally, x-rays can be done either like sitting up or laying down. You can have a bedside x-ray where like in an inpatient setting, if a patient is like not able to leave their room, if they're in like the ICU, or if they're like just an inpatient, then you can have like a portable x-ray come and just take the image of them right there. and the patient, like their positioning, you can have a lot of flexibility with like if they're sedated or unconscious, they don't have to be like standing up to cooperate. And then lastly, it's a relatively low dose of radiation compared to other imaging modalities like CT is probably one of the higher ones. And so with radiation being a risk for having DNA mutations accumulate over time, the risk, is still very low if you're having it be just, every once in a while to have imaging done. But we still keep track of patients, especially with chronic illnesses that require a lot of repeat imaging, that we try to not give them too much radiation, especially in children and in pregnant women. Those are considerations that we have. And then, of course, like when you're working in a healthcare field, if you're around radiation, then you wear lead to protect your endocrine organs and your other organs from potential ionizing radiation. So those are just some of the pros of X-ray. Cons, it still is radiation. So like if you have to image somebody, like you're probably going to give them some dose of radiation, and none is better than some, but it's not always an option to just do ultrasound or something that doesn't have any radiation at all. And then also, like I kind of mentioned earlier, X-ray is really not that good for certain pathologies. So soft tissue evaluation is really poor, especially like the abdominal organs and the GI tract, and it doesn't even really show anything in the brain because your brain is surrounded by like a thick skull, a thick bone skull. And so X-ray is really good for evaluating bones because they're really like they stand out well on the films versus like soft tissue. It just kind of all looks like these weird shades of gray that don't stand out very well. And so it's not super sensitive for a lot of things, but it can still be a good starting point, especially if you're not sure what's wrong. And then you can kind of work your way up as you have a better differential for what is going on. Then you can escalate to like getting a CT or an MRI. In certain circumstances, like if you're suspecting a stroke, like you're going to just jump right to a CT because one, you don't have the time to waste, and two, like that X-ray is not going to work. So you just go to the thing that is going to work. But for these sorts of like trauma situations where it's like pretty high acuity and you can get a lot of information from an X-ray and like you might have to go back and do more later, this is a good starting point. Just to kind of walk you guys through the normal thoracic anatomy. So in a perfect world, like everything would be nicely labeled for you on a chest X-ray and you would know exactly like what you're looking at and all the anatomy would be perfect. But unfortunately, it does not work out like that. So you have to have a really good understanding of anatomy, even in just like a normal healthy person, to know like what things are. And then especially when they're wrong and if they're unhealthy and they have abnormal findings, then it's even harder to identify. So I don't expect you guys to like memorize this chart at all. I just wanted to have it as like a comparison for what it looks like on an X-ray. So again, like there's a lot less definition. There's a lot of variability, like I said earlier, between like patient positioning and just like people's individual variants of anatomy too, can be very challenging to translate something like this to this. But just to kind of walk you through what's normal. So we'll go through the process of like what order you look at stuff, but looking at their trachea here, this is the airway coming down in the midline. It might be slightly off to the left depending on the patient and the position that they're in, but it should be relatively midline. And then it's going to branch into your bronchi here. You can't really see it on X-ray. They're just drawing it so that you know approximately where it's going to be. Obviously, this big like white silhouette in the middle is the heart. And they've labeled the different atria and ventricles, but you really cannot see that on a real X-ray. You just kind of know that this is the cardiac silhouette. Sometimes you can see a nice little aortic knob of where the aorta arches over and starts to go, it starts to descend. And then the other things here, like the lungs, again, you can't really see the lines of where the different lobes are split, but you can kind of estimate like if someone has a like a right upper lobe pneumonia, then like you'll see that the consolidation is like limited to only here and then everything underneath it is clear. So it's kind of you can tell, but like not all the time. So let's see. Yeah, we talked about the airway. You have your heart, you have your lungs here. These are the outlines of your diaphragm. Usually it's actually a pretty nice, like sharp line that you can see. So your diaphragm you have your right hemi and your left hemi. They usually form these nice little deep angles that go down towards the abdominal cavity. And then, like I said before, so you can see sometimes the gastric bubble, or if there's like gas in your stomach, or if there's food or liquid or whatever. So it can kind of look a little bit jumbled, and that can be like variations of normal. But that's kind of where your abdominal organs and abdominal or GI tract starts, is down below the diaphragm. And then lastly, if we're looking at all the bones, so we have our clavicle here, that's your collarbone. The scapula, this is your shoulder blade. That's on the back side actually. So you have to also remember that this is a 2D image of a 3D person. So like this, you can also see like the vertebrae, but the vertebrae in the back is going to be on the back side and not the front. And there's not really any depth that you can use to tell us. You just kind of have to know where it's supposed to be. But yeah, we've got like our clavicle, our scapula, and then you can also see the shadows of our ribs that are lining the thorax. So I know that that's a lot of information. I just wanted to make sure that everyone had like a good baseline of what we're looking at. And we'll talk through kind of the more specific applications of it in a second. So this is going to be really the meat of the presentation today. We have a systematic approach to reading chest x-rays, and it follows this little A, B, C, D, E order. The first one being airway. The first three, spoiler, are airway, breathing, and circulation, just like the ABCs for like every other thing in medicine. So we're looking at the airway. Is the trachea open? Is the trachea midline? Do the bronchi have any foreign bodies in them? Is there any like endotracheal tube? Is the patient intubated, or do they have like any other like tubes or accessories that are present? So I'm going to show basically for each one, I'm going to show what you're looking for, and then I'll show an example of like what things you might find would be. So here, can anyone tell me what airway finding you see?
I'd say the airway looks pretty fine. There's not a lot of fractures, and it looks midline because it's still proportional. It's just slightly crooked.
Yeah, it is just very slightly crooked. So if you like kind of draw a line, it's still pointing down a little bit. But it like the other one, it also was pointing in that direction. So it's again kind of hard to tell. It's kind of a judgment call, and you have to use clinical context of like what's going on. And I did kind of jump the gun here, but because we just did a pneumothorax case and you guys know what it looks like here, you can also see that this like angle of the diaphragm is very much like deeper and wider than the other one. And so that combined with, if we wanted to call this a deviated or a shifted, a mediastinal shift or a shift of the airway to one side, then we could call this a tension pneumothorax. But the main thing that I wanted to show here was the airway can look like shifted more to the side in a pneumothorax. If I go back, maybe if it'll let me do this. Here, actually, you can see a really nice, like where the bronchi split off of the trachea. And especially in like little kids who have like sudden onset coughing or wheezing or something, and they were totally fine before, and then they all of a sudden have this like breathing problem, that you can also look to see if they have like a foreign body or if they aspirated something or are choking on something that fell into their lung. So this has like kind of a nice branching point here, but you don't always get to see that. So that's airway. Next is breathing. So we're going to basically just be looking at the lungs and see, are they symmetrical for the most part? Are there any masses on a chest x-ray would show up like more white, they'd be more dense. So we're looking for those. We're looking for vascular markings. Like I said before, with pneumothorax, like it could look like little streaks of fluid or like white things that are branching off kind of horizontally from the midline, and those are the pulmonary vascular markings that are supposed to be there, but like, do they look really congested or do they look like they're not even there? And then like comparing the size of the lungs and the expansion of the lungs as well, like we did with the pneumothorax, where it's like one lung looks way hyperinflated and there's no vascular markings compared to the other one that's like of a normal inflation and normally expanded. So if we're looking at the lungs for breathing this time, can anybody tell me what you are looking at with this one?
Yeah, again, this one's better because it's less deviated, so I don't think it's a tension
I
pneumothorax.
agree. Yeah, that it's a nice midline airway.
Yeah, and the diaphragm seems to be closer towards the right place. There might be some fluid in the lungs though, but
Absolutely. Yes. So you can see like comparing the two lungs, like this already looks a little bit congested on the right side, but this whole, or sorry, the left side, but this whole middle lobe here is just full of like something, some fluid. You can tell like if you're comparing between the two, like this is a lot more like whiter in color. And that's kind of what I was saying before, how like you can't really see the lines that separate the lobes of the lungs, but this is like pretty clearly the right middle lobe because there's nothing going on really in the upper lobe. And then you can imagine that this lower lobe, like it does maybe look a little bit fluffy, but it's not as bad as this middle lobe. So this is going to be a picture of a consolidation in the right lung. And this is actually from a patient that has a lobar bacterial pneumonia. So this is all of that like inflammation and like gunky bacteria and white blood cells that are trying to fight off the pneumonia in this one lobe of the lung. And then also as a quick bonus, like if you notice that the diaphragm on this side, like kind of doesn't have that nice angle that the other one does, that's something called a pleural effusion. And that's where sometimes you get like reactive inflammation from being like, if you have it with pneumonia, then you can get this like buildup of fluid in the pleural space. And that's a pleural effusion when you lose that angle. So that's just kind of a bonus, but I wanted to really illustrate this lobar pneumonia. It's just this white consolidation for you guys that is definitely, you can tell that it's not the same on both sides. And then this is also a good picture of how the gastric bubble, like it almost looks like it's a hole or something, but that's just air that normally exists in the stomach. And it can fluctuate in size depending on if the last time that somebody ate or drank something. So this is actually like a really nice gastric bubble. Okay, C is for circulation / cardiac. So really like here, we're just looking at the cardiac silhouette and its size and then correlating it to if there's any other things that are happening with the patient. So this was the example that I wanted to show you guys. So this is a normal cardiac silhouette. I don't remember if I already mentioned this or not, but typically you would consider anything from 1/3 to 1/2 of the distance between the entire thorax. So from edge of the lung here all the way to edge of the lung here, the cardiac silhouette should be no more than half of that total distance. And the heart also sits on slightly to the left side of the body, so it's not totally symmetrical. Unfortunately, it's not one of those ones that you can use symmetry as kind of like a way to cheat and read something. But you can probably pretty clearly see in this other slide here that that is like way more than half of the total distance. And we've also got all of this like fluid and gunk and just crap aeration in the lungs, basically. So this is actually demonstrating something called cardiomegaly. And that is, like I said, if it's greater than half the distance of the thorax. We see this really blurred cardiac silhouette compared to this, where it has really nice borders and you can see exactly where it is. This has so much fluid overlying it in the lungs that you can't even really see the silhouette. We can only just see like the opaqueness of where the heart's supposed to be. I think Adam was saying congested right lung. Maybe that's for the last one. Sorry, I haven't been looking at the chat. But yeah, so we're seeing all of this like bilateral fluid buildup, and that is a finding called pulmonary edema. And that's basically where you have fluid in the lungs. And it just looks really like, I've heard it just described as fluffy, and I think that's a great way to explain it because it just looks like a bunch of like clouds almost in the lungs. And this is a diagnosis consistent with congestive heart failure. So we get really big, like enlarged heart because of all this, like the muscle being out of whack and having pathology there. And then it causes all this fluid buildup through the pulmonary vessels, and it just all kind of leaks out into the lungs. And it's not a good picture. This is a terrible chest x-ray. Adam was asking if this is what CF would look like as well. And that's a really interesting question. I don't think I've ever actually looked at a chest x-ray for somebody with CF, but I would imagine that because they do have like chronically just really thick, heavy mucus in their lungs, that it would probably look similarly really bad and just have a lot of fluid and stuff that's built up and trapped in their lungs. So that's a great guess. And I would agree that that's probably similar to what it looks like. They just would likely have a normal sized heart. And again, sometimes with the overlap, you can't totally even see the borders clearly. But in a CF patient, because it's just a purely lung problem, they wouldn't have any heart problems or heart like findings on chest x-ray. So that's a great observation. All right, moving on to D. This one's a little bit of a stretch, but it's for disability, or really what they're meaning is bones. So looking at their ribs, their clavicle, their vertebrae, sometimes you can even see their like humerus and their arm bones that are in the shot as well. So we're looking for like continuity of those bones. Do they have visible fractures? And then also here you can really use symmetry as your friend, and you can use those outlines and shadows to help make sure that the lines are all like lining up with each other nicely. So first, looking at this one, does anybody know what the diagnosis is? I'll give you a hint. You want to look carefully between the two sides and use your symmetry. Yes, Julia and Bridget got it, and Sammy. It's a broken clavicle. So this is a right-sided clavicular fracture. You can see here, it's just, completely snapped. And compared to the left side, it's like a nice straight line. So yeah, that person has a broken clavicle. And then here, this one's a lot more tricky, but I'm going to see if you guys, I'll give you a hint. It's the bones, because I know that this lung also looks pretty crappy here. It looks very fluffy and like it's got a lot of edema. But does anybody have any idea of a problem with the bones? It's really subtle. I definitely would not get this if I didn't know exactly what I was looking for. Dislocated shoulder, that's a good guess. I always think that shoulders are dislocated, but so much of the joint is that it's positional. Like if they're just twisted differently, the symmetry really doesn't work well. But yeah, like you can like see this here. It totally looks like it could be dislocated, but it's actually fine. Emanuela said slight rib fracture, and she is absolutely correct. So if you're looking here, like if we're tracing the outline of this rib, it's going up, 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 up. And then we get here and it jumps up again. And we've got this little fracture right in the middle of the rib. So you can really use the continuity of this line to your advantage, because if you just trace it and you see this like discontinuity, then that's a very clear pathology. Now, this doesn't always work because like these are your, oh gosh, what are they called? This is like where your cartilage meets the rib. And so it kind of looks like there's a little divot here, but so some of it can be normal. But if it's in a space that you like would anticipate for things to be like very continuous, and again, like the difference is that like in here, this is a nice continuous line and this is a nice continuous line. Whereas like these little breaks in the ribs here are just the attachment points, and like almost every single one you can see that. So again, it's just a lot of pattern recognition and trying to find like little subtle differences in that. So this is, like we said, a slight rib fracture. We also, if you had picked up on how there's no vascular markings, basically like if I were to trace where the pneumothorax is, it's around here. Like this is where the lung is collapsed into, and the rest of this is just completely free air in the pleural space, and there's no vascular markings like there you would see on this side. So Likely what happened was this rib fracture punctured the lung and caused a pneumothorax. Again, very subtle. It's hard to pick out. And then the last thing, E. E stands for everything else, very catch-all. It's not super helpful because there's a lot that you also have to look at. But it's pretty much like, do you see any other weird things that we haven't already looked at? So it could be medical, like, what's the word I'm looking for? Like stuff that we gave to the patient, like a line, a tube, an EKG lead. Do they have like surgical clips, sutures, staples, the gastric bubble that we talked about before? Like, is that in the right place? Do they have free air under the diaphragms, or are there other abdominal findings? So I'll show you guys a couple of examples of what like everything else could mean. And I don't know, it's kind of a stupid step because it's just everything. So there's a couple things here. What do you guys see? Swollen heart could be a good guess. Yeah, I would agree. I think that like if you measured the distance from side to side, that this would be more than half. So I think they probably have some cardiac. Um, Julia is saying markings near the spine, not sure what they are. I think you're probably talking about these little like loops, and that is absolutely correct. So these are actually um, surgical wire sutures from a previous surgery. Likely, what they had was some sort of heart disease that they needed surgery on their heart for. And so they did something called a median sternotomy. It's where you basically just crack the chest down the sternum so that you can access the heart. And when you sew the sternum back up, you use these metal wire stitches and they leave them behind. So that's what these are. That's why you're able to see them on x-rays, because they're actually metal. And that was what was used to close the chest after a surgery. So I think that's probably what Adam was referring to as well. Again, this is a 2D picture on a 3D person. So you would have to know in their history that they had like a heart surgery in the past. Otherwise, like it would be totally reasonable to think that these might be like part of the back or near the spine. And when you're just getting started, like there's no way that you can really know that. So this is likely from a past heart surgery. And then also I wanted to point out that, hold on. Can you guys still hear me okay?
Yes, I hear.
Okay, I got a notification saying that I was logged out, but it might have not been from Zoom. I don't know what it was on. Okay, sorry. So this little bubble here that looks almost like a gastric bubble, but it's not because there's no stomach on that side. This is a very bad sign. This is where you get free air under the diaphragm. And you can see the diaphragm is like lifted up and it looks like this little skinny like bridge over the rest of the abdominal contents. And this is a very bad sign because it indicates some sort of GI perforation, whether that was from like, I don't even know, a bowel obstruction that ruptured, or a ulcer, or a gunshot wound, or like so many things. But basically, if your GI tract perforates, you get gas that fills your abdominal cavity and it lifts up your diaphragm like physically, and that's where you get this free air. And free air is a surgical emergency because there is something wrong with your GI tract that needs to be fixed ASAP. So that's the other finding here, along with these little surgical sutures. Where did my other thing go? I thought I had, oh, actually, never mind. I remember I put it in the quiz. So there's another, this is a hint for the quiz. There's another thing that's under everything else that is going to be like a foreign body, I guess, on chest x-ray, like something that the person wasn't born with. And it'll be very obvious what it is. But Yeah, so just be looking out for like history of like surgical procedures. Anything that like shows up like metal um, is something that is would fall under the everything else category. Okay, so back to our case. So this was our patient's chest x-ray. We kind of talked about it a little bit already, but these are the normal vascular markings that we would look for in a typical lung. That's the pulmonary arteries that are branching off and supplying the lung with blood. And on the other side, we see this little tiny shriveled up lung that doesn't have any vasculature that's branching off of it. And we also see all of this just open black airspace that's surrounding it. So that's one sign of the pneumothorax. We also talked about how the airway was slightly deviated to the right, away from the side of the pneumothorax. This patient luckily did have a normal cardiac silhouette. I would say that this is probably fits in the normal ratio that we're looking for. We did not see any visible fractures, no rib fractures or clavicle fractures or any other things that we would be worried about from the trauma of his car accident, and also no other significant findings. So back when we were talking about the risk for abdominal bleeds, X-ray would not be a very good way to evaluate for that. We would actually use ultrasound. It's called a FAST exam. I don't remember, focused abdominal something for trauma. Sonography, focused abdominal sonography for trauma is what FAST stands for. And it's basically a way to look for free air, free fluid in the abdominal cavity, but you wouldn't see that on chest x-ray, and we'll just say that they did that and it was fine. So his final diagnosis that we said was going to be a tension pneumothorax, which is a collapsed lung due to the perforation of a lung pleura. And this diagnosis is based off of his history, his physical exam, and his chest x-ray. So the first step to treating a pneumothorax is to always make sure that your airway is secured. Like if he had an oxygen saturation of like 70 and his blood pressure was like tanked and he was just not able to like support himself to stay alive, then we would intubate him immediately. That'd be the first step, is to secure the airway. With him being stable, we're going to treat with what I had said before is this needle thoracostomy / decompression. And this is going to relieve the compressing air to allow for the lung to inflate. So that's like what I was saying, when you like pop a balloon and all the air rushes out, that's kind of like what we're doing here. So the technique for it is to use a large bore IV or catheter, like a 14 or a 16 gauge needle that you insert into the second intercostal space at the midclavicular line. That's a lot of like anatomy terms. Basically, it's just going to go like kind of in the space below the first rib under your collarbone with the midclavicular line. So the like right in the middle of your collarbone, midline through it. So it'd be like, I don't know, like around either side, like right here. I don't know if you can even see what my video is showing. And then you would follow that up with a chest tube and then confirm the chest tube with another chest x-ray. So I'm going to show you guys this video, and it has like a little description and demonstration with what the procedure looks like.
Normally, the parietal and visceral pleura are closely adhered together. In a pneumothorax, there is a puncture of visceral pleura, and now air rushes out into the pleural cavity. In a tension pneumothorax, there is a one-way valve where the air keeps accumulating in this space. It will compress the heart to the opposite side. This is a tension pneumothorax.
That's where you get the airway deviating to the other side.
To treat this emergently, we release the air by a needle thoracostomy. We choose a 14 or 16 gauge IV catheter. Feel for the second intercostal space in the midclavicular line on the affected side. We insert the needle. That should release a gush of air. Once the patient's blood pressure has stabilized, we also insert a chest tube.
Okay, so hopefully that kind of like put into context what those different procedures are. It's like a pretty fast thing. Like once you identify it, the needle just goes in, all the air basically comes out, the lung is able to reinflate. And then the chest tube's a little bit more involved because it's a bigger procedure, but at that point the patient's been stabilized, and so it's usually like a little bit more controlled.
Normally,
Oh, sorry. Okay. I always like to end my things with a little chat about the specialty that we talked about today. So, a little bit about radiology. So, radiologists, like, very often will just work independently. In my radiology rotation, they just kind of like sit in their little dark room with all the lights turned off, and they're on the computer looking at scans, and they just kind of like will go through the scan and then chart about it and like report the findings. So there's a lot of technology involved. There's always constant updates and upgrades and everything to the different imaging modalities and ways that we can help understand and visualize patient problems. So a lot of it is like you're just given this like empty chest x-ray or CT or any of these things that haven't been read, and patient has something wrong with them, and the consulting physician is just kind of like, okay, figure out what's wrong. So it's like solving a puzzle. Um, so if you like those things, then you might be a great radiologist. Radiology generally doesn't have a ton of direct patient contact. They kind of tend to just like work to help other physicians make diagnoses, but that's not to say that there can't be any. In fact, like for procedures like fluoroscopy, where if you do like um, a barium swallow, for example, to evaluate for esophageal or GI abnormalities, that's like done in real time. So the radiologist is having the patient drink this radio opaque solution and then taking the pictures of them. So they're like with the patient and helping them through that procedure. But a lot of the time, they do not have direct patient contact, and they just work to help other doctors make diagnoses. To be a radiologist, you'd also want to have an excellent understanding of anatomy. So if you're really passionate about learning about anatomy and all the different variations of anatomy, then this might also be an interesting career field for you. You would want to know the indications for different imaging modalities like the ones that we talked about already. And then also radiology is known as one of the best lifestyles in medicine, because generally it's either shift work or there's like no emergencies where you would have to physically be at the hospital to like take care of a patient and save their life. Outside of like, of course, residency, where you have to do like initial training and other things first. But once you're an attending, they generally enjoy a very nice work-life balance. So to become a radiologist, you would need 4 years of med school. You would have a 4-year residency in diagnostic radiology, and then you can also subspecialize with doing a fellowship in pediatrics, interventional radiology, which also interventional is a super cool field. I actually considered doing it. It's pretty competitive, but it's almost like you're doing like mini surgeries that are always guided by cool imaging and stuff. For example, one of the ones that I helped with was using like a fluoroscopy guided injection of chemotherapy directly into a liver tumor so that it would try to preserve the rest of the healthy surrounding tissue and really concentrate the treatment specifically in that one area. So it's pretty cool. You can do like a lot of targeted therapies. Sorry, went on an IR rant. But breast, cardiothoracic, and then nuclear medicine also is like a cool one where you can kind of track the activity and physiology of cancer. So like the uptake and metabolic function of different like cancers, tumors, and be able to help with treating those as well. So very cool fields with awesome technology, good lifestyle generally, and pretty good pay. Makes radiology like fairly competitive amongst medical specialties, but we always need great radiologists and people who are good at these skills and passionate about these issues. So if that's you, then this might be a great career path. Looks like we did have one question. Adam was asking that I think probably if we were going, was it the free air under the diaphragm? Let me see if I can find it. Yeah, so that's a great question. So let me see if I can find. I don't know if I ever mentioned this, but this formal name is called pneumoperitoneum. Okay, here, this is a good one. Can you guys see this? So here on the left side or on the right side, we see the normal, like, well, it's not normal, actually, it's bad, but the free air under the diaphragm. And then here we almost see like a double rainbow where you have like, this is maybe the gastric bubble here. If they have a really empty stomach, it's full of a lot of air right now. But then you also have this like hemidiaphragm that's sitting on top of it like that. So that's like an example of one on the left side. And sometimes it doesn't always show up on both sides, but you only need one for it to be a problem. This is a really bad pneumoperitoneum. So great question though. Okay, let me get back to this. So these are my sources. If you're interested in radiology, actually, I highly recommend the website Radiopedia. They have a ton of free imaging and cases to like walk you through different patient presentations. They've got a great educational library. So it's this Radiopedia, spelled, I think, the British way. So yeah, if you're interested in that, you can check that out. And then lastly, the only thing left is for you guys to fill out that quiz. So if you had any questions or any problems with any of the questions that are on there, then we can take some time and go back to any of the slides that would help you with that. Otherwise, just give it your best shot. And I just wanted to say thank you again to everyone for coming today. And I really enjoy doing these. So if there's any other topic that you're interested in doing, then please leave it in the feedback for on the SOAP note and quiz, and then we can get you a topic that you're interested in. So thank you for coming. It was great to have everyone, and I hope you learned something. If you have any questions, I'll be around. And also questions for anything, doesn't have to be radiology, doesn't have to be like related to the case. If you have anything about medicine or applying to med school or anything like that, just let me know. I'd be happy to chat. I usually stick around on the Zoom until there's only like 1 or 2 people left. So feel free to log off if you are ready to and don't need any more of the PowerPoint to help with the quiz. Otherwise, I'm just going to kind of be hanging out until people start dropping off the call. Side note, does anybody know if they want to do radiology at all? Is that like a primary interest for anyone? I know it's like still super early for everybody, so.
I wasn't before, but I'm actually really interested in it now.
Oh, that makes me so happy. That's awesome. Yeah. It's a fun thing. I think like and especially like as you go on through medical training, these types of jobs where you have both the ability to really impact patients' care and get to work on solving parts of their puzzles and putting together all of their clinical history with formulating a diagnosis can be very satisfying. But then you also have, you know, on the spectrum of lifestyle that you get to kind of enjoy a lot more freedom compared to other specialties is very cool. Shirley was asking, how does the match and residency process work? Does the med school you go to matter? That's a great question. So I'm currently navigating the match right now, or at least trying to. I haven't applied. I will in September. But essentially, the timeline is basically that you go through your first 3 years of med school, and then your 4th year is when it's time to decide what you'd like to apply to go into. Most people just pick one specialty, but some people can't decide, or they are wanting to do something that's really, really competitive, like let's say orthopedic surgery or dermatology, and they're skeptical that they're going to be successful in applying to just that specialty. So they might also apply to something that's less competitive, like for example, family medicine or pediatrics or internal medicine or something like that. And then you generally will send in your applications around September. And it's almost just like med school applications where you have a personal statement and your transcripts and your standardized test scores and your letters of recommendation and your list of activities and extracurriculars and everything like that. And then you check off all the boxes of the programs that you want to apply to. And the number really varies depending on the specialty that you go into and how competitive you are. So like the more broadly you apply, that's generally more recommended for people who have a weaker application or who, I don't know, just like are in a really competitive specialty. And then you will interview in the fall, so like October to December, January. And then this is where it gets a little bit more interesting. So based off of the interviews that you have gotten, you can then rank your top programs in order of which you'd like to attend them. And then you submit your rank list, and then the programs that you interviewed at will also rank their ideal applicants. So, like, say you've got somebody with like went to Harvard and cured cancer and was published in Nature 4 times and is a, like, I don't know, refugee and invented time travel, then they would rank them first. And then they would rank everybody, and then you'd get to like Olivia Snyder from Iowa, who's like pretty average. And then, like they, have their own order of how they'd like to rank people. And then the algorithm will then match you according to the mutual rank. So like say that my top choice was to go to University of, actually, I'll just say like Mayo Clinic. I just went to an open house with them today and they seemed really nice. So let's say that my top choice was Mayo Clinic and I ranked them first and then they ranked me fifth, but then like their other top 4 people ranked Harvard. Then I would potentially be able to match with Mayo Clinic, and then that's where I'd go. And then the second question was, does the med school you go to matter? And I would say no. It's way more about how you do in medical school and what you do with your time compared to the actual school that you attend, with the caveat that unfortunately, international or like especially Caribbean medical schools tend to have a lot harder of a time in the match, regardless of specialty, compared to US schools. But I think between MD and DO, they're now integrated into the same match process. So there's a lot less difficulty and barriers with DOs entering specialties and programs that were traditionally for like MDs. And then your actual school ranking or prestige does not really matter that much, especially like if you just kind of like did average in school and maybe your board scores aren't super great and you weren't involved in a lot of things and you have pretty mediocre letters of recommendation from a great school. That's not going to be as good as someone who went to like a state school and had a really awesome experience and is passionate about their specialty and has great letters and has great test scores and lots of leadership and service experience, or maybe some research involvement. So it's just kind of like the same game, unfortunately, as medical school admissions, but just you get to really focus in on what your personal interests and goals are, which I think makes it a lot more bearable of a process, despite it's still very rigorous and it's still a lot of unknown and uncertainty to navigate. I feel a lot less stressed going into this application season, even though anesthesia is like fairly competitive, compared to when I was applying to medical school. Like I was just absolutely a wreck. I was like, is anything ever going to pay off? Am I even ever going to be a doctor? I would much rather go through this process and do medical school all over again than have to go back to the uncertainty of being pre-med. So I would say that like if you can at least get through this stage of life and get into med school and just continue being passionate about learning and showing up on time and working hard and being nice to people, then that will get you as far as you would ever want to go. Sorry, that was a very long answer, but it's just like very relevant to what I'm going through right now. So I feel like I have actually like a decent thing to say about it. Hopefully that helped. Yeah, you're welcome. Thank you for asking.